Good evening, everybody. So, I'm Dr. Srinivas Shinde. So, today we are here on Facebook Live. For a very important topic of living with lymphoma. So, today we have a very senior consultant and a reputed hematologist and oncologist from India, Dr. Shyam Aggarwal, who is a senior consultant and chairperson and director at the Department of Medical Oncology at Sir Gangaram Hospital. So he has been since 1997. So he has completed his medical college graduation from Rohtak Medical College, and also his professional trainings from UCLA, Los Angeles, St. Vincent Hospitals, University of Ames, and other. He has been actively participating in various clinical trials and experience in conducting various clinical trials and bone marrow transplant. So I would like to welcome Dr. Shyam Aggarwal on behalf of all of us to proceed to the further talk on Hodgkin's lymphoma. Thank you very much, and Dr. Shyam.
Thank you, Dr. Srinivas Shinde, for your kind words. I welcome you all to this live telecast of awareness on lymphoma. Today is World Lymphoma Awareness Day, that is 15th September. And I, along with my colleagues, Dr. Srinivas and Dr. Sachin Minhas, who is the research worker, PhD, post-PhD with me, bringing you greetings from Sir Gangaram Hospital. So as was pointed out earlier, we've been engaged in the management of patients with lymphoma, Hodgkin's and non-Hodgkin's, for the last over 30 to 35 years. And we have seen several new developments in the field of non-Hodgkin's and Hodgkin's disease. So on this Lymphoma Awareness Day, we would like to share our thoughts with you and try and bring you update as to what is happening in the field of lymphoma in the world. So the idea is to disseminate knowledge, and Dr. Srinivas and Dr. Sachin will moderate the question answer session at the end of my speech. So I will get started with the slides. So as I said, we bring greetings from Sir Gangaram Hospital, and I'm thankful to Horizon Conference who is hosting this program. So next slide, please. So what are we going to discuss? So I think you have to understand that lymphoma is not one disease. Lymphomas are not the same disease. It is very important to understand. And the type and the grade of lymphoma, as is depicted by the pathologist, dictates the treatment and the long-term outcome. So these two statements are very, very important because depending on the pathology, the grade is decided and that dictates the treatment. So as I said, stage of the lymphoma again is very critical as for any malignancy. So I'm introducing the word malignancy or cancer here because lymphoma is considered to be a malignant disorder of the lymph nodes, which means that it is arising from the lymph nodes, as I will show you, from the neck, from the axilla, and from the inguinal region, and even in the abdomen. So the subtype of the disease is not uniform, and that's what I said in the first statement, that all lymphomas are not the same. Another important thing which you have to remember, that there is no predictability in a given patient about the outcome or the behavior of the disease. So that is where the science, even till date in 2020, lacks the ability to predict that this particular patient will be cured and this particular patient will not be cured. However, in the next statement I make here, that if you are detected in an early stage, stage 1 and 2, then you are looking at a curable cancer in 90 to 95%. So which means that if you are diagnosed in stage 1 and 2, Hodgkin or non-Hodgkin lymphoma, 95 out of 100 times, one patient will be cured. But if the stage is more than stage 3 and 4, well, then you have still a chance of cure, but then the chances go down to 60 to 80%. And you have to still understand that we cannot predict in the beginning who is going to be cured and who is not going to be cured. So we treat the same patient or all patients as per international guidelines, which are, for example, laid down by NCCN or by ESMO or by NICE, etc. And even the Indian guidelines are there. And we expect and we hope that the patients are cured. Next, please. Next slide. So this is a busy slide just to show that, as I said, you can have lymphomas of non-Hodgkin's. I first focus on non-Hodgkin that can be arising from the B lymphocytes or T lymphocytes. And as you can see, there are more than 30 subtypes of lymphomas, and the treatment for each type of lymphoma is going to be different. And this diagnosis, what type of lymphoma one patient has, is purely the prerogative of the pathologist, and that depends on the staining and the biopsy, which is critical. So biopsy for the patient is important and is essential before you start any treatment for non-Hodgkin's lymphoma, unless there is an emergency where the patient comes in a very sick stage, where we can perhaps rely on an FNAC or a needle test. Next, please. So in order for us to diagnose non-Hodgkin's lymphoma, as I said, morphology, which comes from the biopsy. So ideally a full lymph node should be removed, and that gives the pathologist the full material where they can do the immunohistochemistry and, if needed, flow cytometry, and even certain other tests like cytogenetics or FISH test. These are technical words which are there with the pathologist, and the whole idea of doing these tests is to identify what precisely is the type of lymphoma which a particular patient has, which will determine the treatment of that particular individual. Next, please. So you can see here, you have the B cell type of lymphoma in more than 90% of the patients. T cell is 5 to 10%, and diffuse large B cell lymphoma is the most common type. And these are the other uncommon types like follicular. I'll talk about those. Mantle cell I'll talk about, and the indolent or the CLL or SLL. So these are the various subtypes. I can't go into the detail because of the paucity of time. Next, please. So this is the important slide which tells you how to stage a patient with lymphoma. When you have the biopsy diagnosis, for example, a patient comes with nodes in the neck which are enlarged, you do a biopsy and the pathologist says that the patient has non-Hodgkin's lymphoma. Then you have to see what stage of lymphoma it is. So if it is only one group of lymph nodes involved on one side of the diaphragm, then it is stage 1. If there are two or more than two groups of lymph nodes, but on the same side of the diaphragm, stage 2. So these two stages, as I told you, if you have a patient with lymphoma in these two stages, nearly 90 to 95% will get cured. However, if you have disease on both sides of diaphragm, it is called stage 3. And if, for example, stage 4 is there, when you have disease involving the bones, liver, bone marrow, or other parts of the body, then it is called stage 4. So diaphragm is one issue, and the other issue is the other organs involvement, which gives you the staging. Next, please. So now you can see various types of lymphomas have various 5-year survival, which is termed as cure. So diffuse large B cell, as I showed you, is the commonest type. I think this is a little old slide, but then 60% of these patients can be cured. I'll show you later. But the other types of lymphomas can live for a longer time, especially the low-grade lymphomas, which I'll just come to. Next, please. So you don't have to worry about the diagnosis of lymphoma too much, because majority of the patients go on to live for 5 years and beyond. So this is a detailed kind of pathology slide to show this is the cells look like. I'll not go into the detail. Next, please. So now coming to the staging part. So once you got a diagnosis of lymphoma, a PET CT scan is desirable today to diagnose and do the staging. As you can see, these yellow spots, these are the nodes which are enlarged in the abdomen and in the chest. So this basically will make this patient as at least stage 3. And a bone marrow test is also important for all patients of non-Hodgkin's lymphoma for staging purposes. But important to remember that PET CT scan is an important tool to look at the nodal involvement. Now you can see these are the axillary nodes, and this is the neck node. Next, please. So they light up like this. So this is the the chemotherapy which we do for most of the patients of non-Hodgkin's lymphoma. And this is an old slide in which CHOP, this is a 4-drug regime: cyclophosphamide, vincristine, adriamycin, and prednisolone. And you can see a 3-year estimate of around 54%, which means that if you treat 100 patients, so 3-year survival for these patients will be to the tune of 54%. This is when you use only CHOP-like regimen in which you have 4 drugs, CHOP. The other protocols, they don't offer any advantage, and therefore CHOP has become the standard of care for all patients of non-Hodgkin's lymphoma, particularly DLBCL type. Next, please. So now there is some detailing going on, although it has not impacted the treatment. Based on certain further immunohistochemical stains, you can divide them into germ cell type or activated B cell type, where the results can be a little different. This is theoretical, but let's go on to the next slide. So now you can see, depending on the CD10 staging and certain BCL6 and MUM1 staging or typing on the immunohistochemistry, GCB type does better than as compared to non-GCB type. But the treatment for both is still R-CHOP, as I'll just tell you. Next, please. So now, about 25 years ago, it came the understanding of the CD20, which is a target which is present on the B cells from where the DLBCL arises. And then came this particular drug, which is called the monoclonal antibody rituximab. So this brought in a new agent which changed the thinking of treatment of DLBCL. Next, please. And this is how it changed all over. Rituximab, which is the monoclonal antibody against CD20, when combined with CHOP regimen, so the results are better than as compared to CHOP alone. And since last 25 years, the addition of rituximab to CHOP has become the standard of care. And technically, we doctors call this as R-CHOP now for all patients of DLBCL. And you can see the survival is a shade better. So from 55%, the cure rate has gone up to nearly 65%. That means still, unfortunately, 35% patients will still relapse, but they can still be salvaged, as I will show you. Next, please. So this is another concept in, International Prognostic Index, depending upon the LDH, depending upon the B symptoms, and so on. So if somebody has no bad symptoms, then their survival is much better than as compared to patients who have 5 bad symptoms or signs. So this is another staging system to devise the prognosis of a given patient, but then the treatment still remains R-CHOP today. Next, please. So now this is the role of autologous bone marrow transplantation or hematopoietic stem cell transplantation. This is what I said, that 35% patients will be relapsing, and then you subject them to a second-line chemotherapy followed by autologous transplant. And as you can see, nearly 50 to 60% of patients can still be cured. This is, 60 months, which is 5 years, 75 months, which is more than 6 years. So after salvage transplant, out of those 35, nearly 50% will be cured. So which means that even in stage 3 and 4, nearly 80 to 85% patients will be able to achieve a cure. So which is a fairly good number at this point in time. Next, please. So I think this is what I said, that you can salvage nearly 50%. I think we can go to the next slide. So this is again to show that patients, nearly 50-60% can be salvaged by autologous stem cell transplant in diffuse large B-cell lymphoma. Next, please. So I think we'll skip this slide. Next, please. I think next. Okay, so now coming to the next type of lymphoma, which is a follicular lymphoma. I think this is what the pathology looks like. So DLBCL or diffuse large B-cell lymphoma is an aggressive lymphoma. Follicular lymphoma is a low grade or an indolent lymphoma. Next, please. So it grows very slowly. So this is, T14-18 translocation is there between 14 and 18 chromosome. And this is how the follicles look like in the pathology. Next, please. So you can grade the follicular lymphoma depending on the centroblasts. So that's what I'm showing these slides because the pathologist has a very, very critical role. So if your pathologist is not good, well, then there can be a mishap, a grade 1 can be graded as grade 3 or grade 3 can be graded as grade 1 because the treatment is different for grade 3A and 3B and even a grade 4. So therefore, it is very, very critical to have a good pathologist to look at the lymphoma slides so that you get the correct diagnosis. Next, please. So again, these are some of the features, which is the International Prognostic Index, like the age, the stage, the LDH levels, hemoglobin, and depending upon these features, again, the outcome of the patient can be different. If you have 0 features, then the 10-year survival is 70%. If there are more features, bad features, poor prognosis, 36 months, or 36% will survive at 10 years. Next, please. So again, this is to show you that people who have good IPI, 0 or 1, well, they live longer than as compared to patients who have high IPI. Next, please. So let's skip these slides in the interest of time. Next. Okay, so now this is very important. So this is the treatment for follicular or indolent lymphoma. So if somebody has stage 1 or selected stage 2, then you can cure them with radiation. So that is given with the curative intent. But by and large, 90% of the patients of indolent or follicular lymphoma are diagnosed in advanced stage, majority of the patients. And if they are asymptomatic, then you don't treat them. It is very difficult to convince a patient that you have a lymphoma and the doctor is saying, wait and watch, because you cannot eradicate these indolent lymphomas. And that is why you want to wait and watch, because there are patients who can go on to live for 4 years, 5 years, longer without any treatment. Chemotherapy will give them trouble. So that is why we want to withhold the chemotherapy until they become symptomatic. So again, you have the bendamustine and rituximab, which is another drug along with rituximab, because most of these are B cells or CD20 positive. However, we can use other regimens also. So, but rituximab is become the standard of care for low-grade lymphomas. Next, please. So this you can see you see this is the initial treatment for all patients. Nearly 18% of the patients will have observation, means wait and watch, don't do nothing. And patients, for example, chemotherapy with rituximab is given to nearly 50, 60, 70%. Some patients are also given rituximab. So indolent lymphoma is a separate group where slow treatment can lead to a long life, which could exceed beyond 10 years or 20 years even. Next, please. So there is a role of rituximab maintenance in follicular lymphoma, as you can see. So you give only rituximab, which is not chemo, at a 3-monthly interval, and this goes on for at least 2 to 3 years, and these patients can live longer. Next, please. So for relapsed disease, we have several lines of treatment, as I said, bendamustine, then you can have R-CHOP, then you have R-DAP and R-ICE, and so many other treatments, including transplantation, which can be given in a sequential fashion to prolong the life of a given individual. So indolent lymphomas cannot be cured, but people live a normal life for long periods of time by and large. Predictability is not there, which is a big issue, which I said in the first slide. Next, please. So you can see, the median survival is 13.5 years for patients who undergo transplant for follicular lymphoma. So they can go on for long periods of time with normal quality of life. Next, please. So I think we'll skip these slides. Next, please. Next. Okay, so this is one more type of lymphoma, which is called mantle cell lymphoma, which is usually in advanced stage, and people, for example, who have GI involvement, extranodal involvement. So then you should think of mantle cell lymphoma. And there is a 11-14 translocation in the chromosome with male predominance. So, pathologist has to diagnose mantle cell lymphoma based on the CD5 and CD23 staining. Next, please. So this is to show you the prognosis. Again, there is a scoring system on which the patient survival is there, but the mantle cell lymphoma is considered to be an aggressive lymphoma. Next, please. So you can see the current thinking for mantle cell lymphoma for aggressive type is R-CHOP alternating with R-DAP, or some people use this hyper-CVAD, which is another complicated regimen. But I think R-CHOP alternating with R-DAP is becoming the standard of care for patients with mantle cell lymphoma. And in certain cases, like for follicular lymphoma, one can do wait and watch. Again, that comes from the pathology, a particular stain called the SOX2 stain, where you can decide whether you can wait and watch. But by and large, mantle cell lymphoma is an aggressive disease, and there is a role of autologous transplantation for upfront for patients in mantle cell lymphoma, which we need to discuss case by case basis. Next, please. So when they relapse, then you do have other drugs. For example, I'll talk about the BTK inhibitors, but then you have several drugs which are available, including transplantation in the end. Next, please. So this is the role of transplantation. Again, 50% patients can be cured. Next, please. So this is another type of lymphoma. Now coming to the T cell types. T cell lymphoma is an aggressive lymphoma by and large. They are not that chemosensitive than as compared to B cell lymphomas. But then the treatment remains CHOP, and depending on the stage, the results are not that good. Next, please. So this is, again, you see the curves, coming down to 30%, 40%, and depending upon the subtypes, these are not as good as the B cell type, but fortunately, T cell lymphoma is only 5% or so of all the lymphomas. 95% are B cell types. Next, please. So we'll skip these treatments. Next. So these are some of the salvage regimes. If the R-CHOP has failed, then these are other combinations like ifosfamide, carboplatinum or cisplatinum or etoposide, and these are cytarabine based or platinum and gemcitabine based. We have these new drugs like ibrutinib, lenalidomide, rituximab, bendamustine. So you have several drugs to offer to these patients, and offer bone marrow transplant if they have failed the initial regime, which is the R-CHOP regime. Next, please. So I think next slide, please. We'll skip this. Okay, now, so I think there are so many types. I'll just come to the next slide also. But I think for lay people, it is important to also understand the previous slide, that what are the side effects of chemotherapy. So, nausea and vomiting have come down quite a bit with the availability of newer anti-nausea drugs, particularly drugs like granisetron and even Akinzio, which is available. Bone marrow suppression is an important side effect in which the TLC goes down or white blood cells go down, and these patients' immunity goes down, and they are prone to getting infections, especially in the first 10 days. Oral ulcers and diarrhea as a result of chemotherapy can be bothersome in the first 7 to 10 days. Some nail changes, darkening of the skin, alopecia or hair loss. It is very important to understand the cardiotoxicity, and therefore all patients have to have an echocardiogram before we give them R-CHOP, which contains adriamycin, which is a cardiotoxic drug. And for young people, infertility is important, and therefore you need to cryopreserve the sperms or ova before we give them chemotherapy, because a small percentage of patients can lose their fertility due to chemotherapy, because chemotherapy is acting on dividing cells. It doesn't differentiate between cancer and the normal cells, and that is why all this toxicity is there. Next, please. But it's all reversible by and large. So lymphoma can affect any part of the body. Brain lymphoma is again curable, but then the treatment is different. For example, high dose methotrexate. Testicular lymphoma involving testes is a separate entity in which there is role of brain prevention like intrathecal chemo. Stomach and intestinal lymphomas are usually diagnosed after operation, and they still need, R-CHOP like regimen for diffuse large B-cell lymphoma, similarly for head and neck. So, the point to make is that lymphoma can involve any part of the body. Next, please. And you have to treat them appropriately. So now, an important question which patients ask, and we have been saying that there is lack of predictability. So how do you monitor these patients? So as I showed you, that you do the PET-CT in the beginning, at the end of 3 or 4 cycles, and then at the end of 6 cycles. And PET-CT is the ultimate. And if you have achieved a normal PET scan, then you expect that everybody should be cured. But unfortunately, as I said, the cure is only there in around 60% of the patients in the first line R-CHOP. So why do they relapse? Because the PET-CT can only detect tumors which are bigger than 5 millimeter. And the problem is that the 5 millimeter or more bigger tumor contain more than 100,000 or even 1 million cells. So there is no technique to detect the presence or absence of 100,000 or a million cells. So if there is a small 1,000 cells or 10,000 cells lingering on in the body of a patient, which is called microscopic disease, and that cannot be picked up by a PET-CT or any investigation in the world, they gradually grow bigger, and they usually are responsible for relapse in the 2 years time. So, so that is the fallacy of PET-CT, and that is the inability of the doctor to tell you that you are cured. And you only have to follow up every 6 months or so. And if you don't relapse for 2 to 5 years, then we tell you that you are cured of this disease. Next, please. So the final slide is on Hodgkin's lymphoma, which is the other type of lymphoma. Again, you see early stage lymphoma is stage 1 and 2 when the disease is confined to 1 or 2 node areas. And there again, you do 2 to 4 cycles of chemotherapy followed by radiation. And in this category, you can expect to cure more than 90%. Early stage unfavorable, especially if the node size is big, there again, the treatment is the same, like the 4 cycles of chemo, which is the standard ABVD by and large 4-drug regime, as you can see here, followed by radiation. And in patients who have advanced stage, in which there is stage 3 and 4, or patients who have B symptoms like fever, weight loss, or sweating. So there we give them 6 cycles of chemo and radiation to the bulky disease, and there you can expect to cure 60 to 80%. And there is a role of interim PET-CT, as it is called, that after 2 cycles of chemo, you do a PET scan, and that also can modify your treatment. Next, please. So I think this is what I said. The follow-up requires 4 to 6 monthly examination by blood reports, X-ray, ultrasound, and an appropriate CT scan or a PET scan. Next, please. So these are some of the new developments which have happened in the field of non-Hodgkin's or Hodgkin's lymphoma. I told you about the diagnosis part, GCB or germinal center type or activated B cell type, but the treatment remains the same. So ibrutinib is one drug which is now available for treatment of mantle cell lymphoma in a relapsing patients. Lenalidomide has been added to R-CHOP, but the results are not very clear. So new antibodies like polatuzumab is going to be launched, and it's available on compassionate use for non-Hodgkin's lymphoma who have failed all standard chemotherapy drugs. It's an anti-CD79 antibody. Adcetris or brentuximab is the drug for Hodgkin's, unfortunately not available, but people are using it for upfront Hodgkin's also, but it is very expensive at this point in time. And even for CD30 positive anaplastic large cell lymphoma. Immune checkpoint inhibitors like nivolumab and pembrolizumab have done wonderfully well in Hodgkin's lymphoma, relapse setting, and primary mediastinal B-cell lymphoma. So what I'm trying to tell you is there are many new developments in the field of Hodgkin's and non-Hodgkin's lymphoma, which can help you live a normal life, good quality life, and possibly provide you cure for more than 60, 70, 80% of the patients, even in advanced stages. First or second stage can be cured in over 90%. So I think, next slide. So I think important points to remember are that all lymphomas are, this is the same slide which I showed you first. I just want to reiterate, all lymphomas are not the same. Grading of lymphoma as determined by the pathologist or the type of lymphoma is very, very crucial. It must be done maybe 2 times for all patients so that there is no confusion in the type of or the grade of lymphoma. Staging is very important. Different subtypes will have different treatment, as I told you, and still predictability is not there, and you can cure a lot of these patients. Next. So I think I thank you for your kind attention on this World Lymphoma Awareness Day. I wish you good luck, and hope that I've been able to explain to you in simple terms what lymphoma is, how to stage, and how to expect the best outcome for a given patient with Hodgkin or non-Hodgkin lymphoma. So thanks. And now over to the moderators, Dr. Sachin and Dr. Srinivas, if there are any questions from the audience.
Well, thank you, Dr. Shyam, for such a wonderful talk. Am I audible?
Yes, you are.
Yeah, thank you, sir. So, sir, in the larger interest of patients, I would like to ask a few questions.
Go ahead.
Are there any precautions that the patient needs to take when he or she is undergoing the treatment?
Yes. So as I told you, chemotherapy is the mainstay of treatment for patients of whether Hodgkin's or non-Hodgkin's. And as I explained, that these chemotherapy drugs are acting on dividing cells because cancer cells are dividing. So unfortunately, these chemotherapy drugs do not differentiate between normal dividing cells and the cancer cells which are dividing. So the dividing cells are present in various organs of our body. For example, our hair are growing. So they will act on the hair follicles and be responsible for loss of hair, which is called alopecia. But the worst and the most important side effect is on the bone marrow, because the WBCs, they will go down, and WBCs contain neutrophils, which is the main fighting force for preventing or treating the infections. So once your WBCs go down as a result of chemotherapy, so this patient will become prone to infections. And that happens in the first 7 to 10 days after each dose of chemotherapy. So you have to take precautions, like you have to not take fruits and vegetables because they can carry infection. You have to take cooked food and packed food and packed juices, etc. No fresh juices. So because those can carry infection. Second or third point is that you should try and remain indoors for the first 7 days or so, because the more you go into crowded spaces, you can get infections. So I think that is the most important precaution. And the third or the final thing is people have to take high protein diet in order to build up their immunity. So if you're a non-veg, you can take egg and other non-vegetarian food. But if you're a vegetarian, just stick to milk and milk products so as to boost your immunity by taking a high protein diet like dry fruits. Right. So these are some of the precautions which are there.
Great, sir. Thank you. So you have been treating lymphoma for almost like 2-3 decades. Sir, have you seen a change in treatment? Let's say in the last 10 years, have you observed how treatment has evolved and changed?
Yeah, so that's a very, very interesting question. Yes, things have certainly improved, as I showed you in the slides. So, before 1990 or so, which is nearly 30 years ago, right? 1990 is 30 years ago. So CHOP, 4-drug regimen was the mainstay of treatment. Then in 90s came rituximab. So, our CHOP has still remained the bread and butter for most of the diffuse large B-cell lymphomas. Yes, as I showed you, for low-grade lymphomas like follicular lymphoma, bendamustine has been now incorporated as the first-line treatment. For mantle cell lymphoma, we have R-CHOP alternating with R-DAP. So some improvements have taken place. Now the understanding of brain lymphoma, where you have high-dose methotrexate as the first line treatment now, has now become the standard of care for 15 to 20 years. So some areas have improved, but if you ask me for diffuse large B-cell lymphoma, R-CHOP has still remained the standard of care, which actually is the bulk of the non-Hodgkin's lymphoma. This is about non-Hodgkin lymphoma. Now, about Hodgkin's disease, Hodgkin's lymphoma, which is a different type of lymphoma. So ABVD, 4 drugs, adriamycin, bleomycin, vinblastine, DTIC, has remained the bread and butter. But in the last 2 years, I told you about brentuximab. So the problem with ABVD is it's a very good combination, which is curing of almost 80 to 90%. But then bleomycin, the B, in a very small, tiny percent, which could be 2% or 3%, it causes lung damage. And that lung damage is irreversible. And it's a hypersensitivity reaction. I have seen patients dying with bleomycin. And it is so very sad to see a curable disease where bleomycin causes death of an individual. So, what has happened is that brentuximab vedotin, which is an anti-CD30 antibody, has come in. But then it is so expensive. It runs in lakhs of rupees. So unfortunately, not available in India. So, ABVD still remains the standard of treatment, number one. The second regimen, which has come in Hodgkin's disease, is called a 7-drug regimen, BA-COP regimen. So, in which you have 7 drugs. So this is kind of very aggressive protocol, and it is reserved by and large for young, fit patients who have, say, stage 4 disease. I've used the BA-COP regimen, but the toxicity is profound. It is not meant for patients, for example, who come from outstation, say from Bihar or from Punjab or Haryana. It's a cumbersome protocol and giving a lot of suppression of immunity. So, but then it is a little better protocol than ABVD regimen, but then people have to accept the toxicity, which is the point. Although the cure may be 5% more or 3% more, but then you have to see the cost benefit, see the socio-economic status of the individual before you choose the product. So, technically speaking, for majority of the people, for non-Hodgkin's, it is R-CHOP, and for Hodgkin's, it is ABVD regimen. So, which have come to stay with us. But newer drugs have come in, as I told you in my last slide, like immune checkpoint inhibitors and other agents.
Right. Thank you, sir. Sir, next generation sequencing. Now, these days, we get to hear about next generation sequencing in a lot of cancer. So, is there any role that NGS can play in lymphoma?
So, since this is meant for lay people, so next generation sequencing is a test in which you can subject the tissue to sequencing, gene sequencing in a particular machine. So when you do that, the idea is to detect genetic abnormalities in that particular tumor. So unfortunately, at this point in time, it is not a routine test to be recommended for patients of lymphoma. And the problem is, you can perhaps identify the gene defect in the tumor cell, but the actionable mutation is invariably not there. And therefore, we are not promoting the NGS, but I think there is a future there for our ability, because now the science is so advanced that you take the tumor tissue, and not only the tumor tissue, I've had patients where even the blood sample can be taken, and that we call as liquid NGS. So just take the blood sample and send it to the lab, and the lab person will tell you that these are the genes which are abnormal. But the problem is you don't have too many drugs which can target those gene mutations, especially so for Hodgkin's and for non-Hodgkin's lymphoma. The test is available. And I have done this test for a few patients, but we haven't gotten a lead where we can treat according to the gene mutation and salvage that patient.
Right. We can find the mutations, but we don't have any medicines targeting these mutations. So there is no point doing that.
So people who can afford, we are doing it because the test is so readily available. I mean, at the price of 30, 40, 50,000 in India, it's just available, and the tissue is there. and people are asking for it, and sometimes we are doing it also. But I'm at the moment, skeptical of a positive result to get from
Right.
NGS in lymphomas.
Right. So talking about genes, sir, so many of the patients may have this kind of question. Is it genetically inherited? Let's say if I have it, then what is the chance of my daughter or my son having it?
Right. So the one thing is uh, the incidence of lymphoma in our country is to the tune of nearly 50,000 new cases develop lymphoma each year. And let me say this, that if you look at the Globocan and the ICMR data, the incidence is rising every year. And that is particularly for non-Hodgkin's and Hodgkin's both. So we don't know why this incidence is going high. And not only in India, even in the Western countries. So the linkage of the, this particular cancer is with, say, viruses. And EB virus particularly has some role to play, which we don't clearly understand. So what I'm trying to say here is that this lymphoma is by and large not hereditary. So if somebody has had it in his or her family, or somebody's parent or mother or father or grandfather had it, it is, I think the generation is at the same risk of getting this lymphoma as the normal individual. So this is considered to be an acquired illness. It is not inherited, and it is not passed on to the generations by and large.
Right. Thank you, sir. So my final question is, sir, even though we don't really know why it happens in the first place, but still, would you like to suggest a few, lifestyle changes that a person can make to make his or her chances, decrease the chance of developing this type of cancer?
Right. So, there is no specific thing which we can tell, but in general, when we talk about cancers, so if you are leading a normal, healthy lifestyle, which means that you are not eating a lot of junk food, which, a lot of youngsters today are doing that by going to McDonald's and to Pizza Hut and to Domino's. I mean, what to talk, my children, I mean, they're all fond of all this, but then that is not good, because that gives you a lot of, fat, which is there in that pizza and etc., which is in the cheese. So you're supposed to take more of green leafy vegetables. You're supposed to take more of fruits. So now in the public, schools, private schools, as I think you've seen the surveys, obesity is becoming an issue because people are putting on weight. And now that this lockdown is there, the activity, physical activity is missing. So people are putting on weight left, right, and center. So gaining weight, obesity, no activity, sitting on the computers, sitting on the cell phones gives you all this bad thing, and no green leafy vegetables, no fruits. And now on top of that, if you add smoking and drinking, etc., for young adults, so also remember that Hodgkin's and non-Hodgkin's lymphoma is a disease of, younger individuals, 20 years, 30 years, 40 years. So it is not a disease of elderly people. By and large, it is the disease of people between 15 to 20 to 50 years age group. Although Hodgkin's has a peak for an elderly people also, but then by and large, these are people who are in the productive age group. So I think these are some of the precautions which people have to take when in order to avoid the occurrence of any malignancy, including Hodgkin's and non-Hodgkin's lymphoma.
Great, sir. So these are all the questions that I have. Dr. Srinivas, if he has any questions, he may go further.
Am I audible?
Yes, Dr. Srinivas. Yes, please go ahead.
Just I have one question. Do you have any experience in lymphomas on immunotherapies? Do you have any patients such?
Oh, yes. So, Hodgkin's lymphoma is extremely, extremely sensitive to immunotherapy. And let me tell you or remind you, I think Dr. Srinivas was also involved in the treatment of that particular individual, where this particular patient has undergone several lines of chemotherapy, ABVD, RIs, platinum-based, and bendamustine, and so on. And then this patient came to us dying in the ward with liver studded with cancer. And this patient had bilirubin because the liver was totally failed, and it has bilirubin of 7, 8, 9, and patient was unconscious. This patient was given immunotherapy in the form of a drug called nivolumab, and within a span of 5 days, his bilirubin came down and he started walking on the 7th day. This patient went on and on to live for at least 2 years beyond nivolumab. Number one case. The second case, who I can never forget, and maybe he's listening to me, this patient had undergone 2 lines of chemotherapy, patient had undergone bone marrow transplantation, and even another line of chemotherapy, including brentuximab. That patient failed. He was 27 years of age then. And then we started using this nivolumab in that individual. He took nivolumab 2 years. He has absolutely normal PET scan for the last 3 years. And I am proud of telling you that he got married and he's got a child now. So immunotherapy in Hodgkin's lymphoma can turn the entire trick in favor of the patient. Similar results of nivolumab or pembrolizumab can be achieved in primary B-cell mediastinal lymphoma. So, but Hodgkin's is such a success story for nivolumab and these immunotherapy drugs. And now these drugs are now coming in the first line. So the trials are ongoing at this point in time. So there's a huge, huge promise for the use of immune checkpoint inhibitors in Hodgkin's lymphoma. And you must offer it to everybody when these patients have failed at the moment, first or second line of chemotherapy.
Okay, thank you, sir. Thank you very much. So I have a final question. We are already short of time. So post-treatment, what there could be long-term complications, and what are the alarming signs when patients should immediately come to the hospital or follow-up?
Right. So that's a very good question because let me tell you, so as I said, 50,000 new cases are diagnosed every year currently in India. And now I told you that nearly 70% will be cured. So 70% of 50,000 is nearly 35,000 people are living every year. So now you count for the last 15 years. So 35,000 multiplied by say 20 years is 700,000 people, means 7 lakh Indians. 7 lakh Indians are living with lymphoma, cured lymphoma now. So now you can imagine, so they could be facing problems of chemotherapy and radiotherapy after 5 years, 10 years, 15 years. So what are the problems, which is what Dr. Srinivas asked, are long-term problems of chemotherapy or radiation. So now, what has happened is, so earlier radiotherapy was used a lot in the neck lymphomas, or because these lymphomas usually arise in the neck and in the axilla. So when you do the radiation to the neck or to the axilla, then radiation causes damage to the thyroid. So patients were developing thyroid cancer after 10 years or 15 years, number one. Patients' breast, ladies particularly, the breast was exposed to radiotherapy, and there was a higher incidence of developing breast cancer. Similarly, chemotherapy drugs, they cause damage to the cells, and those cell damage can lead to the development of cancers, second cancers like acute leukemia after 15 years. So the incidence has gone up a little, not very high, but 2-3% or so. So second cancers, thyroid cancers, breast cancers are issues which one, or thyroid, even thyroid can fail. You can have hypothyroidism as a result of thyroid getting radiotherapy. So I think we addressed the issue of infertility. So which is another important issue because these drugs can damage the gonads or testes or ovary. And the final thought is on the heart. Because if somebody is given radiation to the left side of the axilla or the left side, the heart is also exposed, or the mediastinum is exposed. So that can damage the heart. So now what has happened is that I think we didn't go into the details for Hodgkin's lymphoma. So 20 years ago, as Dr. Sachin also asked, what are the changes you have seen? So earlier, people were giving 6 cycles of chemo. So now we have reduced the number of cycles to chemo to 2, 3, or 4 because adriamycin is a cardiotoxic drug. Number one. So when you reduce the number of cycles, the damage to heart is less. Number two, the techniques of radiotherapy to the mediastinum have become so refined that they spare the heart, and therefore the heart damage doesn't occur in the long term. So, these are some of the long-term side effects which we see with these chemotherapy and the radiation agents.
Especially, it is very helpful to all the medical practitioner students, and also for the common public. So thank you very much. And I would like to thank Dr. Sachin also for question session, and especially Horizon for arranging this conference. Thank you very much.
With this,
Thank
we
you,
thank you.
everybody.
And thank you for listening and being patient. Thank you.
Thank you so much, sir. Thank you. Thank you. Thank you, sir.